Hello, my name is Fady Youssef, and I am a staff physician at the Jennifer Moreno Department of Veterans Affairs and an assistant professor in the Division of Gastroenterology at UC San Diego. I would like to thank the ASGE and the editors of GIE for the opportunity to share our study's findings. On behalf of my co-authors, I'll be discussing our article, Pancreatic Cyst Features Predict for Future Development of Pancreatic Cancer, Results of a Nested Case Control Study. Pancreatic cysts are common. Prior studies estimate pancreatic cyst prevalence of 3 to 20%, which increases with age. The concern is for prevalent pancreatic cancer or development of future pancreatic cancer. Currently, we do not have good strategies to predict which pancreatic cysts are at high risk for development of pancreatic cancer and which pancreatic cysts are low risk or will never progress to pancreatic cancer. Pancreatic cyst surveillance is based on guidelines derived primarily from expert opinion or studies of surgically resected cysts, and this introduces significant bias and limits the real-world generalizability. Three of the most commonly used guidelines for cyst surveillance include the 2017 Fukuoka Consensus Guidelines, the 2018 European Guidelines, and the 2015 AGA Guidelines. To address the current research and clinical care gaps, the aim of our study was to evaluate patient and cyst-specific factors for development of pancreatic cancer among patients with pancreatic cysts using a large national cohort with long follow-up. We utilized a nested case control study design using a previously reported retrospective cohort of U.S. veterans with pancreatic cysts. Cancer cases had baseline pancreatic cysts and subsequently developed pancreatic cancer on follow-up. Controls were a 1 to 3 random sample of those with pancreatic cysts at baseline without pancreatic cancer on follow-up. We excluded main duct IPMN, as these are recognized to harbor higher neoplastic potential. We also excluded suspected benign cysts in individuals with a history of acute or chronic pancreatitis to minimize inclusion of non-neoplastic cysts. Among our study base of 7,211 veterans with pancreatic cysts, 78, or 1.1%, were confirmed to have suspected branch duct IPMN and develop pancreatic cancer 1 year or later after cyst diagnosis. 72 pancreatic cancer cases met inclusion criteria, and 265 controls were identified. Pancreatic cancer cases were older at the time of cyst diagnosis, 74.4 years versus 67.4 years, but other demographic characteristics were similar between the two groups. In terms of radiographic features, pancreatic cancer cases had larger cyst size at diagnosis and higher proportion of pancreatic duct dilation and enhancing mural nodule. And Fukuoka high-risk stigmata and worrisome features were more frequently identified in cases as compared to controls. Pancreatic cancer cases also had a greater change in cyst size, median 5 millimeters versus 0 millimeters, and increased cyst growth rate, median 1.9 millimeters per year versus 0 millimeters per year for cases and controls, respectively. On univariable analysis, age, cyst size at diagnosis, change in cyst size, cyst growth rate, pancreatic duct dilation, enhancing mural nodule, and presence of any Fukuoka high-risk stigmata or worrisome features were significantly associated with increased risk of pancreatic cancer. On multivariable analysis, age, hazard ratio 1.03 per every 1 year, cyst size at diagnosis, hazard ratio 1.03 per every 1 millimeter, cyst growth rate, hazard ratio 1.22 per millimeter per year, and pancreatic duct dilation, hazard ratio 3.78 for 5 to 9.9 millimeters, and hazard ratio 13.57 for 10 millimeters or greater, were significant predictors for pancreatic cancer. Our study confirms multiple findings surrounding pancreatic cancer risk among individuals with pancreatic cysts and expands upon existing evidence gaps. We identified age, cyst size, cyst growth rate, pancreatic duct dilation, and presence of mural nodule as risk factors for development of future pancreatic cancer. Our study also more confidently establishes cyst growth rate as a predictor for future pancreatic cancer. In addition, by utilizing a study base representing a usual care population, we have extended confidence in the importance of these risk factors. Future research efforts should focus on quantifying the predictive properties of concerning imaging features in a usual care population. Of note, a substantial proportion of pancreatic cancer cases, approximately 24%, never developed concerning imaging features, and a substantial proportion of controls, approximately 28%, had high risk or worrisome imaging features and never developed pancreatic cancer. Further research is needed to improve identification of individuals with pancreatic cysts who are at high risk for pancreatic cancer and to identify those who will never develop cancer. Currently, studies are examining pancreatic cyst radiomics and cyst fluid biomarkers. On behalf of my co-authors, thank you for taking the time to learn about our study, and thank you to the ASGE and the editors of GIE for the opportunity and platform to share our study's findings.